Started. We're hybrid today. We're in person and online. And for those of you who don't know me, I'm Esther Chernak. I'm a faculty member here in the Department of Environmental and Occupational Health. And it has been my pleasure to coordinate this year's Population Health Spotlight Series, which is devoted to infectious diseases, prevention, prediction, and perspectives. It is certainly timely in light of the fact that we are maybe in the wake of a major pandemic and are all thinking about and have been thinking about infectious diseases. And we also are going to use this year as an opportunity to highlight Dr. Eli Abertin. Which I'll talk about in a second. I want to, by the way, acknowledge we had a planning committee to develop this series as well as today's lecture, and these are the colleagues from various departments around the School of Public Health, Dr. Anna Akwe, Dr. Goldstein, Dr. Dean Lavasi, Dr. Levasseur, Roth, Mary Cardy, Fred Krebs from the School of Medicine, and Tom Hipper and Josiah Kephart from the Environmental and Occupational Health Department, who helped really brainstorm today's talk, but also the series throughout the rest of the year. But this whole series this year is actually sponsored in part by the Elias Abertin Lectureship Fund. And I just want to say a couple of words about Dr. Abertin to set the stage. So Dr. Abertin was an internationally renowned infectious disease physician. I actually had the great good fortune of training with him in the early 90s and late 1980s, yes, here in Philadelphia. He was a longtime faculty member at the Medical College of Pennsylvania, one of our predecessor institutions. He was an infectious disease physician who was the first fellow to train at the Infectious Disease Fellowship at University of Pennsylvania. He then went on to do the Epidemic Intelligence Service, CDC, a prestigious EIS program. He spent many years at the Philadelphia VA Medical Center, where he was Associate Chief of the Medical Service, Chief of ID, and the Professor of Medicine. That's where I had the opportunity to work with him and to round with him. He then went on to become Vice Chair and then Chair of Medicine at the MCP Hahnemann University. And at the time of his death, he was the Interim Chief of ID and Associate Provost and Associate Dean for Faculty Affairs at the Drexel University College of Medicine. So an ID doc who I think we all knew well, but who had huge contributions here at this university. In addition to his academic appointments, he had been president of SHEA, the Society for Healthcare Epidemiology of America. He was very involved in the American College of Physicians. For many years was an associate editor at the Annals of Internal Medicine, the journal for that organization, and was a governor of the Eastern Pennsylvania region. He was an expert and an author of many studies in infectious diseases with particular expertise in the treatment of endocarditis and urinary tract infections. And he was really known for his erudition, his wide knowledge of infectious disease and medicine. He was truly a scholar, knew everything, knew what was about to be published, what had just been published, what had been published 20 years ago. He was always a voice of calm in times of chaos, and there are lots of chaos on infectious disease training rounds, and really a well-known and respected academician, physician, and a mentor to many. So it's our pleasure to honor him with this series, which this whole year will be devoted to infectious diseases. And I want to introduce Dr. Leslie Silver, who his wife, to say a few words, and his son is also here.
Lovely. Thank you, Esther, and thank you all so much for attending this lecture to remember my late husband, Eli. And my son, Adam, is right here, who came in for this as well. And I'd also like to acknowledge an old friend, meaning from a long time ago, Eli's close friend and colleague, Bob Sherrar. Thank you for being here. So there's one anecdote and funny story about Eli in terms of academic medicine that I'll share with you very quickly. He was a resident at the University of Pennsylvania here in 1968. And right after that, he decided to join the EIS, which was just mentioned at the CDC in Atlanta, Georgia. Epidemic Intelligence Service. So he shipped off to Atlanta with his colleagues, and very shortly they sent him off to Pakistan to study cholera and the cholera situation and to do oral fluid therapy, which was teaching all the locals how to mix very basic ingredients from their markets and drink that to survive cholera. So, of course, before they went off to Pakistan, they all got the cholera vaccine. 3 to 4 days after Eli got to Pakistan, he contracted cholera. So, what do you do? Well, they put him on a hospital boat. And there was one person from the CDC, one of his colleagues, who had brought his family's 8mm movie camera. So you probably don't all know about this. So no sound, but it was in color, and he's filming the whole thing. And Eli is in the hospital boat with an IV in his arm, and they're shipping him off to some hospital. So little digression here. What happened is we have that film today. And, well, let's see, sequentially what happened is Eli was, you can see the film that his colleague took, and there's a close-up, and you can see on Eli's face, you know, am I going to live or am I going to perish? Am I going to live or am I going to perish? Well, we all know the answer to that. He did not perish. And in fact, he ended up publishing the article about this case. And it is today an absolute landmark case, very famous, quoted all the time. He was asked if he could give permission to use that article at Harvard Medical School. So they actually have his article in the Harvard Medical School curriculum. And when they asked his permission, I said to Eli, well, you know, we have AV to go along with it, send in the film. And they were actually showing that film there. So at any rate, getting back to the story, when you see his face and you see him thinking, am I going to live or am I going to perish? Am I going to live or am I going to perish? Well, what he did is he didn't perish, and he did publish. And so I like to say that a little anecdote that goes along with this is a famous phrase from academia that you probably all know, that Eli truly believed in publish or perish.
So thank you. So with that introduction, and we will have an opportunity to honor Dr. Abertin at each of these talks. We have a total of 5 scheduled. I'd like to introduce our first speaker for today, Dr. Meghan Davis. Dr. Davis is an associate professor in the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health and also the School of Medicine there at the Department of Molecular and Comparative Pathobiology. She has an MPH in infectious diseases and a PhD in environmental health from Hopkins with a postdoc in toxicology. And she's also a doctor of veterinary medicine where she trained at the University of California, Davis. And I can also mention she spent years, I learned this last night, as a dairy cattle veterinarian. So what she's going to talk about today is she's the expert. She's the right person to be sharing this with us. Dr. Davis is a molecular epidemiologist and an environmental microbiologist. She studies the interface of bacteria and hosts to reduce microbe-mediated disease in humans and animals. She's the principal investigator of a variety of projects, including the One Health Laboratory at Johns Hopkins University, where her work applies the principles of One Health and microbial ecology. She evaluates the target microbes and bacterial genes in larger microbial community or microbiome broadly. She also examines the interface of bacteria and hosts to reduce microbial disease. In addition, she also studies the non-infectious disease outcomes like asthma and other health conditions from exposure to microbes. And she's the director of the Hopkins POE, Total Worker Health Center, which is really a center dedicated to improving mental health outcomes for the nation's workforce through research, education, and outreach, POE standing for psychosocial factors, organizational conditions, and environmental exposures. Dr. Davis has won numerous awards, and she has numerous interests, including pets and in the environmental transmission of staphylococci. She's doing something called the City Dog Study. She assists with therapy dogs at SHOP, and she is really an expert on a variety of things related to veterinary medicine and human health. In light of the wake of our pandemic, where we all had frontline experience dealing with an emerging infectious disease, it's important to note that the overwhelming majority, 75 to 90% of emerging infectious diseases are zoonotic in origin and really cross that human-animal interface. So it's really my pleasure for our very first talk to kick this series off to welcome Dr. Davis. Thank you.
What are you doing? Here, I've learned I might need to hold this. So I lecture in a giant hall every summer for environmental health. And yeah, I have to hold the mic right here to make it work. So I actually have a funny story that relates to EIS. When I was in vet school, I'm like, yeah, I want to do public health. I want to do veterinary public health. So I did a rotation at CDC in foodborne disease. And what did they do? They sent me to Pennsylvania with the EIS officers. So that was before I even started practice here. I used to practice up in Lebanon. So today I'm going to talk about One Health. Who's heard of One Health? Show of hands. Oh, very good. Okay, so anyone want to give me a definition? What's One Health? Anybody, just shout it out. It's got human health, right? What else? Environment, very good. And animals, right? So it's kind of that Venn diagram where everything comes together. And one of the places where we really think a lot about One Health is in the space of zoonotic disease and spillover. And so what I'm going to talk about today relies more on the work I've been doing in this spillover and health security space. I want to start with a land acknowledgement. We here in Philly, where I was born and raised in Baltimore, and at many of the other institutions or places you might be right now, are on the contemporary homelands of Indigenous peoples. So it's really important that we honor and recognize this tradition. I like telling you what I'm going to do, and then I'll do it. So we're going to talk a little bit, just do a One Health primer, because I think you know what One Health is, but you might not fully know what One Health is. And I think that's one of the challenges we face on a global level when it comes to how we operationalize One Health. It's like, well, we get kind of what it is, but we don't understand how you do it. So I'm going to give you just a little quick peek at how you might do it, and then apply that within the context of H5N1 and our current long-standing multi-year outbreak. A lot of this work builds on my connections with the National Academies of Sciences, Engineering, and Medicine, where I've had a couple of different projects recently, and I know some people like to get the materials early and follow them along. So I'm giving you this ahead of time. So with the INGSA Asia group and in collaboration with National Academies, I was the US chair for a committee that was trying to take, there are lots of guidances out there on how you do spillover prevention, but most of them don't have illustrations and full color and examples and showing you exactly how you might think about putting things into operation. And so we tried to fill that niche with a guidebook for spillover prevention for Southeast Asia. And then quite recently, and in fact, I think published just last Friday, we have the proceedings in brief. I was on the planning committee for a National Academies workshop to really understand where are we in the H5N1 avian influenza outbreak and what do we need to do? What should our research priorities be? So if you're interested in reading that, you can play along at home. One Health has had some evolving definitions. So yeah, humans, animals, environment, we are now formally adding plants. We are now formally adding, but we have goals, right? We have goals to really understand what the effects are with climate change and to help to preserve ecosystems and biodiversity. But it can be a little bit complicated in this space, right? Who's heard of planetary health? Oh, a few hands. Okay, how about eco-health? So I call these the kissing cousins, right? They're very related disciplines that have slightly different ways of doing things. So planetary health is really about now. Right now, this moment, we must urgently safeguard human health from all the changes happening, given that we're exceeding our planetary boundaries and there are, major changes in terms of the climate. EcoHealth has a major, almost I would say, a laser focus on ecosystem health. So preservation of biodiversity, thinking about wildlife ecology, and One Health is really more the one that goes hand in hand with public health. We want to promote human health, we want to promote animal health, we want to promote environmental health, and we typically do so through the programs and structures of One Health, which, you know, if you want to think about planetary health as the hare and One Health is the tortoise, it actually doesn't matter who wins, right? Because we all want to do it. So sometimes you may want to partner on a planetary health side, and other times you may want to say, we're operationalizing things in a way that needs to be sustained through perhaps governmental structures. So that's just my little version of the differences. What One Health does, or how it does it, is through kind of two key areas. The first is systems thinking. Who's done systems thinking? Yes, we're in a school of public health. There is a CEF requirement for a competency in systems thinking, so all student hands should go up. System thinking is about dynamism. It's about how things relate. It's about the relationships, right? So not just the nodes, but the lines between them. And it also, in One Health, is very dedicated to partner group engagement. So really thinking about participatory approaches, indigenous knowledge, and transdisciplinary science and programmatic activities. So this is some of the how. So when we think about systems thinking, who's done laboratory experiments? Great, you're here. This is not a bad place to be, right? Reductionist approaches are critically important to isolate causation. You've got to remove as much as you can that could influence the system in order to really understand how A and B go together, or whatever it is you're trying to study. So these focus usually on a single connection or a single component. Systems thinking is more complex. It's on multiple connections, even connections of connections of connections, right? How food systems and water systems and other kinds of things like built environment, I know a lot of you do urban health, are really critically important. And most important is that it incorporates feedback loops. So there's kind of intrinsic consideration of changes over time. And so I'm going to give you an example. It is Antimicrobial Resistance Awareness Week, so we'll do an AMR example. So I was involved in some thinking about how to take what we call in environmental health, the environmental health paradigm. That's at the top. So you have your sources, you have your different media, food, water, air, soil, dust, and you have exposures like toxicants. You can have how you're exposed, what it does in the body, what it starts to do to the person or the animal, and ultimately the disease you might measure in terms of your outcomes. Infectious diseases do exactly the same. And in fact, the origins of environmental health, the origins of public health are in hygiene, right? Which was about infectious diseases. It was about water systems and waste management. And so we do think about how these two can connect, right? How certain exposures might make you more susceptible to different infectious diseases, or how there might be, in fact, feedback loops. So if we start with the infections, you might get an infection, right? Go to the hospital, or if you're a dog or cat, go to the vet, or if you're a cow, have the vet come to you. And now you've got the infection, so we're going to treat you with an antimicrobial drug. And what does that do? Selective pressure on the population of bacteria. And so now you're more likely to have enriched in your population those bacteria that are resistant, which then feeds back into a loop. And so that's the big challenge, right? With antimicrobial resistance is how do you break that loop? The other piece of One Health that's really critical is this partner group engagement. I want to call out one of my students, Dr. Ari Tagami, who's also a veterinarian. And this is some of the work that we did together with INCSA Asia and the National Academies on spillover prevention. And when we think about partner group engagement, this is really critical. You have to think about bi-directional communication. So this isn't just about, hi, I'm from public health. I am here to tell you what to do. Right, we might know exactly what to do. This might be great. Do you think everybody we come up to is going to say, yep, sure? No. Partner group engagement is about understanding where people are, understanding what their needs are, and specifically thinking about where you can co-design. I might come in and I might say, we need to vaccinate all of our dairy workers for seasonal influenza because we are worried that if you get H5N1 and now you're infected with 2 viruses at the same time, that those 2 viruses might get together and have a little hanky-panky, and then you might get a different virus coming out. Maybe that's good because that virus might not work as well. Maybe it's not so good because maybe that virus now can transmit better to human. Maybe it has more virulence characteristics and causes worse disease. Maybe it has more pandemic potential. But I can't just go up to a dairy worker, and certainly not in English all the time, right? And say, okay, vaccine, let's go. Right? I have to understand where they're coming from. I have to understand what their motivations are and how I might be able to engage in order for us to not only potentially get them to go ahead and take a vaccine and potentially do other things, whether those are wearing PPE or other administrative things they can do, meaning things that they can change about their own behavior to reduce their risk. But I have to know where they're coming from, and I might need to give them some things that they feel they need too. So that's what partner group engagement's really about, and it's foundational to One Health activities. So if we go deeper into that bidirectional risk communication concept, right? At the global level, we have the One Health authorities. We've got the World Health Organization, the Food and Ag Organization, or FAO, the World Organization for Animal Health, WOA. Yeah, it was formerly OIE, Office International des Épizootes, and no, my French is not that good. Apologies to anyone who speaks it. And UNEP, the United Nations Environment Program. So that's the quadripartite. So they feed down into various countries. So we might have the United States, and we've got our CDC, and we have our USDA, United States Department of Agriculture. We have our EPA, our Environmental Protection Agency. We have the FDA, the Food and Drug Administration. And those feed down to our state level agencies or departments, right? Our local Department of Health, our Pennsylvania Department of Ag. Thanks, I was accredited with them for many, many years. They do great work. And of course, then environment. And then that goes down to our frontline workers and also our community members, right? Sometimes through and sometimes separately. So if we're thinking about risk and how we communicate risk, right? Risk communication is part of how we understand what the risks are and how we understand management of those risks, right? Vaccination strategies, wearing personal protective equipment, et cetera. And we here in academia have an important role as part of this, right? We can sometimes be seen as third parties, arbiters of knowledge, important partners in terms of implementation and evaluation of programs, important partners in terms of foundational evidence that might be used to support decision-making. But what's important is that it doesn't go in that one direction, that instead, that there's a lot of communication up and down that chain. Because if we don't know what's going on, the decisions made at the quadripartite level might not actually be connected in any way to the reality on the ground with our frontline workers. Okay, so that's your One Health primer. Let me do a spillover primer. Everybody know what spillover is? Got a pretty good idea. We lived through the COVID-19 pandemic. I call this the pandemic plus era. It's not gone. It's definitely changed. Plus, we have other things going on that have changed as a result of the pandemic. So a spillover, we think about these animal reservoirs, right? These are animal hosts that typically don't get a lot of symptoms of disease, but they allow the virus or the bacterium or the parasite to have a little party and to hang out for a long time, like those guests who never leave, right? So that's a reservoir host. You can also get animals that are transient hosts, meaning they might not be the reservoir and they might get disease. So with avian influenza, we have reservoir hosts that are like ducks and other water birds that migrate. And we can also have these other hosts in birds like poultry, and your songbirds can still get it, and they can get highly diseased, and they can die. Spillover occurs when from either of these, right? So you might have it passing through a transient or intermediate host, or you might have it directly passing through the reservoir into your human population. You can have spillover into 1 or 2 people, 1 or 2 cows, and it might not go anywhere because that pathogen, which is normally hanging out in an animal, has to be okay with going human to human. So that's yay for us, right? Thank goodness that many of the spillover events we think don't go anywhere. But if things are set up in just the right or wrong way, as Raina Plowright, my colleague at Cornell, likes to say, you know, if you've got these holes in the Swiss cheese of the different layers of barriers between us and a pandemic, they all line up, you can have something pop through. You can also, by the way, have this thing called reverse zoonoses, where you have either spillback or, like your pets, getting exposed from a person who's gotten it upstream from some wild animal. So COVID's the great example of that, because we know that many of our pets and our zoo animals, you know, things you might even find in urban settings, not just in these rural areas where I talk about livestock, can still have exposure. And so most of the animals who are companion animals, like dogs and cats that got COVID, got it from their owners. Their owners got it from a person, and they brought it back to the house. So that's also really important to recognize. And I want to call out that my postdoc, Dr. Caitlin Waite, also a veterinarian, and our collaboration with Cummings Vet School at Tufts were really instrumental to some of the work we did here. So what do we do about it? Well, there's something called primary prevention, where you go out and you prevent spillover from happening. You reduce connections at that human-animal interface. So I went to Bangkok and went to a pet market, and there was a lot of animal-human interface there, right? There were a lot of different species. There weren't barriers between people and the animals. Lots of different species were commingled. There were a lot of species that are considered exotic, meaning they're not like a dog or a cat, where we have these populations that have been domesticated for a long time. These are animals that have been wild caught or had been wild caught, you know, within a few generations of the animals that were at that market. And it was all, you know, with sanitation systems that, shall we say, were not high standard, right? You could encounter animal feces pretty much everywhere, and there were other ways you could mobilize pathogens within that environment. So that kind of setting, or if you go to a fair, right? Who's been to a pet expo or has been to, you know, farm show, right? It's great. I have a wonderful time there, but you also can see sometimes multiple species. I used to do, you know, vet checks before animals went to farm show to make sure that I didn't see evidence of infectious disease when I did my exam, so I could give them a certificate saying, yep, you look okay enough to go to farm show, right? So we do have processes in place. So some of that is in that primary prevention realm. How do we stop that exposure from occurring in the first place? But then we also need to make sure that we think about how prepared are we from a public health perspective? How prepared are we to be able to detect an outbreak? That's a surveillance activity. How prepared are we to be able to respond? Containment or countermeasures, like even the drugs or the N95 masks or whatever face shields you need or goggles to help prevent that exposure in high-risk groups. Do we have those? Are those mobile? Like, can we get them to the places where they need to be? So that's the larger spectrum of how we think about the places where we need investment. And you also need to think about investment not just in things like BARDA and having a national stockpile of personal protective equipment, but thinking about your workforce, right? So we mentioned I do a lot of occupational health work. And so I've thought a lot about, is the workforce prepared? And we can think about preparedness in a lot of different ways. One of the ways we've used to think about it comes from one of my colleagues, or a couple of my colleagues, Dan Barnett and John Links, and it's called the Ready, Willing, Able framework. So ready, are you mentally and physically prepared to respond? Willing, are you gonna do it if called, right? Or you can be like, actually, got to get home to my kids or to my elderly parents. I just don't know that I can do this. I've got some other things I need to work on. And are you able, right? So this is where we tend to focus a lot of effort is in the able. Are you trained, right? Do you have the resources you need to be able to deploy? And this can be for small scale emergencies at local or regional levels, like you have a hurricane and you have frontline responders. But we think about it also in terms of these infectious disease outbreaks. So the concept is if you've got all three in your workforce, you have a higher probability of a quality response. So we looked at this with COVID-19. So a lot of this work was co-led by Dr. Catherine Dalton, then my PhD student, and now I'm faculty at Iowa. And we evaluated the veterinary and animal care workforce during COVID. And we were really looking, this was early, this was like July to October of 2020. We were really looking at who were they, what was happening, what training did they have, how confident were they, did they perceive that there were barriers, and then what did it mean in terms of ready, willing, able. And what we identified is, as you might expect, knowledge was helpful, but really confidence was most important in terms of being prepared to respond. And we saw that more in leadership and less in our earlier stage members of the workforce. Those who really felt that there were factors that helped them do their job better were more able to respond. And there were a lot of barriers that really inhibited their ability to respond. So if we think about this on a larger level, what would your intervention be here? Anybody? I'm going to tell you, you need to be confident. And that means you might need some years in the workforce. Yet that's going to be hard to intervene on. Where can I intervene? Barriers. I can intervene on barriers. Exactly. And so then we did a mixed method study. So we followed this survey with a qualitative study where we're still evaluating the responses to really try to unpack those barriers. But I'll talk about a few barriers that we have within H5N1 that I think are important for us to acknowledge and potentially consider as opportunities for intervention. All right, so I shouldn't say who hasn't heard of H5N1. It's been a problem for a long time. In the biz, right, in veterinary medicine, we call it HIPATH, standing for highly pathogenic avian influenza, or HPAI. What this means is it's a whole suite of influenza viruses that tend to cause disease in birds. Avian, right? Birds. When we think of the H and we think of the N, these are designations based on the hemagglutinin and neuraminidase. And really, this just helps us from a genetic perspective. There are absolutely some differences in terms of the avian influenzas related to whether or not they can attach on human receptors. And so for the most part, what you see in avian influenzas is that it sporadically, meaning every now and then you get a jump into a person, usually who's had contact with an infected bird. And this happens globally all the time. A lot of the cases can be pretty severe in humans globally. So what you're going to see in this example with the United States and North America is something a little bit different, a little bit interesting. And so I'll say that this story is both reassuring in some ways and highly concerning in others. So just be prepared going in. With influenza viruses, and you may have heard, who's heard of swine influenza, right? So swine are a great mixing host for different influenzas, which is good for the virus and not good for us. I'll try to always distinguish who it's good for, right? Not good for us when they can mix and match, because that means that what comes out of them can look very different. Why do we have to give vaccines every year for influenza? Why can't we just like rabies? Like you get the vaccine. I got vaccinated like 3 decades ago, and every time I check my titers, I'm still okay. It changes. These are viruses. They swap hats, right? So you got your Eagles cap, you got your Ravens cap. Sorry, a little nod to my hometown, right? So, but you're switching things up. And then sometimes you have a hybrid and you're like, wait, are you an Eagles fan or a Ravens fan? I just don't know what's going on here. That means that you might not recognize it from the perspective of your immune system. So the stranger the virus, the more it doesn't look like what you've seen before, the more likely it is it can evade or sneak around in your body for a while and cause disease before your immune system figures out to respond to it. And we have a lot of different animals involved in all of these processes. So in this story, you're going to hear about marine mammals. You're going to hear about cats. Sorry, cat owners. It's not great for the cats. So we occasionally have avian influenza pop up. When I was in vet school many decades ago, we would see it pop up, usually for a season, and it would go away. That was just the nature of it. You'd race in to respond where you had it in poultry. You'd increase your biosecurity measures to try to lock down your farm. And then you'd wait it out. Waiting it out is not working with H5N1. This has been going on for quite some time. And it's specifically, when I say H5N1, we're talking about clade 2344B, which is an influenza A virus. And it has impacted, I think, hundreds of millions of birds at this point. It's really unprecedented in terms of the scale and the staying power. Up until 2024, what we'd seen was really concerning. So we'd had mammal to mammal spread, especially farmed mink. So who knows what a mustelid is? Mink and what's the other big one? Anybody? Ferret. And what is your animal model for influenza? Ferret, right. So highly susceptible hosts. And then we had this big outbreak in sea lions and other marine mammals, causing major die-offs. This is an image from Peru. But there have been many other mammals affected in zoo collections, in domestic environments, and wild animals. So in particular, red foxes. And we've even had things like a polar bear and a squirrel, right, infected. And so in North America, because this has been happening globally, right, we had the first detection in Canada in 2021, and then in the US, we had wild birds, and then shortly thereafter, commercial poultry. And not long after that, the first wild mammal detections in the US. In late 2023, we don't know exactly when, December-ish, this is an estimate from people who do analysis of the genomes and look at changes like a kind of clock, and then kind of back calculate to make a guess. There was probably a single spillover event into dairy cows, maybe from a wild bird, probably in Texas. And then we first detected problems from a veterinary perspective in February, because there were cows that were symptomatic, they were on multiple farms, and we kept testing for all the usual things. Nope, not that. Nope, not that. All right, let's just throw the test book at them, and it popped for avian influenza, which now, as a dairy vet, I'll tell you, sure, we see influenza sometimes in cows. It's usually influenza D. I think there have been a couple of cases of flu A before this. So this is a big surprise, big surprise. Subsequently, it was confirmed not just in Texas, but also in Michigan on a farm that had received cows from Texas. Can I just say, cow exchange happens a lot in the dairy industry. Yeah, you know, farmers need replacements. They'll go to a local market, buy some cows at auction, or they'll, you know, work it out with somebody they know whose genetics they like, and they'll bring the cow in. They might ship to Canada. Most of the health certificates I wrote for international transport were for cows going to Canada from my farms in Pennsylvania. Thankfully, this is over a decade ago, but there is a lot of cow movement. Very different from the poultry industry, very different from the swine industry. Those are both vertically integrated industries, meaning that there's like a big company that owns almost all the things. They own the animals, they own the processing plant, they own the distribution network, and they contract grow. There can be some independent farmers, but for the most part, they're through these big systems. Dairy farmers, you got what, like 25,000 dairy farms in the US, which means you got about 2,500 or more decision makers. So it's a different environment. So then we started getting the first human cases, mostly in workers, and we started seeing a few response efforts by late April. So by late April, there was a federal order saying, okay, if you're going to move dairy cows from one state to the next, you got to test them. FDA started testing pasteurized milk in May and detected some virus. It was inactive, don't worry, not infectious. But it meant that the milk itself had the virus in it. And these were in places where we hadn't yet understood disease to be in animals. So that was really quite concerning. And then we started doing more like studies on transmission and looking at specific states and how they were responding. And so Colorado is a very interesting case of a response effort that is, which one of these is not like the others. In most states, they were doing local quarantine, and if there were symptoms and cows reported on other farms, they go take a look. The Colorado state vet said, nope, we got a big poultry industry here, and I think we need to get out ahead of this and do more active surveillance. So going and looking for things rather than waiting for data to come to you. So that's the difference between passive and active systems. And so they went out and they ordered bulk milk tank testing of nearly all the dairy farms. So that's actually how Colorado was able to identify the farms, quarantine them, test them through. Even if they tested positive for a while, they just kept testing and quarantining until they were able to release it. And that occurred, I think, just a couple months ago, that they were able to say, we think we got through it. We might be done for now. Should also note that we've had detections in other species. So besides the poultry and the dairy cows, we've now had our first one in swine. It was on a non-commercial herd/flock in Oregon, and not clear just how the pig was not symptomatic at the time, but did test positive. So that caused big concern globally. So where are we on this? So in terms of high-path avian flu in domestic birds, and so you see commercial backyard flocks, just in the last 30 days, we've had over 20 commercial flocks positive. And if you look at the distribution by state, you can see that there are some places that have been harder hit than others in terms of commercial poultry, but that this is most of the US where you've seen it. So pretty extensive. Also, just to note, I mean, we're literally at many millions of birds affected. And this is, I'm not going to go into details on any of these sort of animal health side of things, because I'd want you to be prepared for that. But I will say that these animals get really sick and have high mortality rates with the poultry. Wild birds, it's been in every state. And if you look at just the last 30 days, it's been centered on the Pacific flyway. So now you've got migration with the birds, and that usually leads to spikes in cases. So this is where both Canada and the Pacific coast of the US have really been experiencing a lot. And we've had Hawaii for the first time. And that's also on the Pacific flyway. The status in mammals is concerning because there are a lot of species here. Let me see, I got cats, I've got bears, I've got dolphins and seals, I've got coyote, I've got mink, I've got raccoons and skunks and opossum and the squirrel. Oh, and I've got mice now. And we know it is infectious, not just that it's contaminated because the mouse has been in a positive environment. It can cause infection, including in the lungs. So a big concern is that some peridomestic species like a pest mouse, a field mouse, it could really set up shop. And from a disease ecology perspective, could this be a reservoir? So this is one of those research priority areas that we think we really need to look into, because if we're not sure how things might be getting from one farm to the other, birds and pest mice, peridomestic animals, are potential routes of transmission that can evade a lot of our other mitigation strategies, right? Because if it's on shared equipment, what do? I'm driving a truck from farm A to farm B, what should I do? What do you do in a hospital? If you're going from your contact isolation room A to your contact isolation room B, you disinfect it, right? You wash it. So you can do that with equipment. You can. I mean, you need to be careful about it and make sure you get into all the nooks and crannies, but you can do it. All right, so the dairy cows. At this point, it's been confirmed in at least 15 states and over 500 cows. Now, I want you to pay attention for a second to the genotype. This is B313, and you're going to see that there are a bunch of different genotypes involved. So a genotype, it's a strain, right? So this is within the clade that there's some differences. The other thing is, I mean, it's not great for the cows. Some of them can die, but more of them are what I would call in practice ADR. They ain't doing right. They've got not such a great appetite. And if you're a dairy cow and your whole thing is producing milk, if you're not eating, you're not going to be producing much milk. And now you've got an inflamed udder. So the udder is really key here. And this is the very sort of virologically interesting thing about this particular clade is that it has a tropism for the udder, for the mammary gland. That is not super typical, right, of these influenza viruses. And we think a lot of the spread may be cow to cow through the milking equipment. It also means the milk is the most infectious substance coming out of the cow. In fact, you can test cows, you can swab their noses for the virus, and you're like, I didn't really detect much. And then you can test the milk and go, whoa, she's definitely infected. We got plenty there. You can see the distribution of states. So Pennsylvania, so far, so good. Okay for now. And California is the epicenter at the moment. Here's a dairy farm. Dairy Farm 101. There are a couple different kinds. In Pennsylvania, you'll see a bunch of these in the middle where you have the cows kind of lined up, and you're actually going to milk her there. You're going to bend over and have milking equipment that you hook up. But in California, you mostly see cows like this, where you've got free stalls, meaning the cows are in these barns that have, wait, do you see walls? I don't see walls. No, there are no walls. What do you think about biosecurity to keep wild birds out? Yeah, no. It's actually a major innovation in dairy practice to have these big open barns. Because when you put the cow in that cute little barn you pass on the road to Lancaster, right? And you close all the doors and it's winter, what happens to the inside? What happens from an environmental health perspective? Anybody study air quality? Right, particulate matter, lots of other sort of trapped indoor, at this point, air pollutants. And so the cows can get a lot of respiratory disease as a result of probably these exposures combined with infectious agents. And so this has been a great innovation. It's also been a great innovation for udder health, because if you think about the udder in a cow lying down here, you know, she's pretty close to the manure. You're trying to keep her off of it. But these, you've got these stalls that they go in and they have to lay down onto sand, and it keeps all the manure out in the gutters. So that keeps the udder, and you can see in the far left, sort of a cow with actually a pretty decently clean udder. Remember, microbiologically, it's not clean. So if you drank milk directly from that cow, if you milked her and drank it, do you think that it would be sterile? Right. So the USDA was looking at how is it spreading. And sure, animal movement was a big piece of it, but they also identified that shared equipment and geographic proximity and also shared workers were a big piece of the puzzle. And so this wasn't even just worker A works on farm A and farm B. This was worker A lives with worker B. Worker A works on farm A, worker B works on farm B, and that was a potential route. So we still don't know. This is an association. Those of you who do epi, right? We don't have cause here yet, but it is suggestive that there are many different routes you can see for transmission between farms. And on the farms with the outbreaks in dairy cows, you've seen wild birds affected, poultry affected, and feral cats. That is, cats that sort of live on the farm affected. By the way, these cats are not, the farmer doesn't go to the animal shelter and say, I need some cats. These cats show up and they're like, oh, you have milk and you have birds and you have mice. We're good. Oh, and straw where I can curl up. Yeah, this is good. And so often when I go into dairy farms, I've seen pails of raw milk left out for the cats to drink because, they're kind of begging. And there's this sort of famous, life photo of I forget the cat. The cats do have names in this particular photo, but the cats do enjoy the milk. But this is not so good for the cats. On these farms, the cats have had really severe disease, and it's primarily neurologic. There was the pig in Oregon, as I mentioned, and you can also see these non-commercial flocks, including our most recent cases in Hawaii and Oregon, were of birds that weren't all poultry, and some flocks didn't have any poultry. In fact, I think all the birds in the Oregon case had names. One of the big concerns, though, was that in Hawaii, that particular flock, which included, I think, a goose, a zebra dove, haven't looked up what they look like yet, but they had gone to sort of an animal show just a few days prior to that. So probably not infectious, but Hawaii's now had to issue a statement of notice for all people who might have attended that particular event. So when we think about this, it can get into places that aren't just sort of what we imagine in terms of the rural farm environment. So our dairy workers, thank goodness, have had fairly mild disease. So this is the reassuring part of the talk, okay? The conjunctivitis is not great, though. This is not just like what's little pink eye. If you see the New England Journal image, this is real conjunctivitis. This is like top level. But there have also been some workers with respiratory signs, but there hasn't been a lot of evidence of human-to-human spread among these workers. So if you do trace back and you go to all the people they've had contact with and do symptom diaries, there hasn't been much identified. Now we are moving into a phase where instead of just doing swabbing where they're symptomatic, the plan is to do serologic testing to try to understand asymptomatic cases and whether we have the potential for human-to-human spread, but the second human gets infected but doesn't have a lot of symptoms. So stay tuned. So why do they get conjunctivitis? Well, I said, right? Working on a dairy farm is a full contact sport. And when you are putting the equipment on the udder, right? And what's the most infectious part of the cow? The udder and the milk, right? It's at face height. So this is why face shields are important. This is why respiratory protection is important for those workers in the milking parlor. And that may be the highest risk environment on the dairy farm. For the poultry workers, it's been a little bit different. There's still some conjunctivitis. It's a little more respiratory. You might say, well, why? Well, I'm milking the cow and I get splashed with that raw milk in the eye or rub my eye. That makes sense, right? So I'm directly inoculating the area that shows the symptoms. That makes perfect sense. For the poultry workers, and there was a big kind of like cluster of cases in Colorado when they were having outbreaks in both the dairy cows and poultry. Many were associated with a single, yes, 1.8 million bird is correct, facility. I think it took them weeks to go through the operation. So when poultry are affected, the policy is called stamping out. So you are depopulating these farms. And so they were catching the birds in 104-degree heat. Okay, now I've been on a farm with an N95 and a Tyvek. Thankfully, no face shield. I think like 2 hours later, I'd lost half my body weight in sweat. You needed to take breaks. And these activities can go much longer than would be really what we might recommend from a heat stress perspective. So you've got to think about that risk scenario. right? And now you're telling workers, no, you have to wear personal protective equipment and you can't drink anything because you can't drink through your N95 mask. And it's 104 degrees Fahrenheit outside the barn. Oh, and there are these giant fans blowing. So you can see where this bidirectional communication really needs to happen. You have to understand what's happening on the front lines. But this may be why you see a little more of the respiratory in the poultry workers. What happens is in birds, they don't have udders, right? They're not mammals. So this is a fecal oral transmission route. So they're, defecating, and then the litter and all of the, so the virus can be attached to these smaller pieces of particulate matter that get airborne for various periods of time. And so that is often how you would be exposed by the respiratory route. So far we've had mostly cases in people with contact with infected animals, but we're starting to see more and more cases without animal contact. So the Missouri case, most of you have probably heard of, was a case with other symptoms, got picked up on surveillance, right? They just did a respiratory panel when they came in, got a flu A positive, and with all the other flu A positives from, it was probably like a week, that got batched and tested by CDC for these more odd strains. So they got an H5 positive and then went back, and using very advanced serology, we're also able to say that probably the household member also had it, but didn't quite meet our case definition for reporting. This one also had some genetic mutations of concern, and that's also true for the really severe case in a teen in Canada. Now, the one in Canada is a different genotype. So this is D11, and it's the same genotype that they've been seeing in the poultry infections in Canada, and we don't know how that happened either. So there was some animal contact with pets, but not to any of the known farms that were positive or any poultry. So stay tuned. Last I heard was a couple days ago, still in critical condition in hospital. Oh, and wait, there's more. There's a new case in California of a child, again, without any known animal contact and pending confirmation. But clearly the workers are a big piece of this, right? And these are workers who come from migrant and immigrant communities. They speak not just Spanish, they actually speak a lot of the more indigenous languages like Quiche. And there could be these barriers, right? They might, because of immigration status, have concerns about going and reporting to anyone, whether it's their employer or to any authorities. If you're someone from, I'm from public health, right? You are from an authority. And so it may not be that there's sort of trust already present. You might need to work really hard and work through trusted partners in order to engage. And they also really may lack access to healthcare. So some of these are, temp workers. They're not going to be in a full-time, with employee assistance programs and full healthcare benefits. And so, wait a minute, how do we do flu surveillance in the United States? Also, if you're offering to draw their blood, they may not love that. And as I already mentioned, using personal protective equipment in these environments can be challenging. But I think the surveillance is the biggest piece. We've done some symptom diaries for participating workers, but there was a recent study that showed a 7% positivity rate on serology, with many of those workers not necessarily reporting symptoms or recalling symptoms. So if they're doing symptom recall and that's triggering a test, there may be these asymptomatic cases. So back to the work I've done for Southeast Asia, we thought about, how do you do surveillance? How do we teach people how to do surveillance? So from the perspective of H5N1, we have a bunch of different areas, right? So we've got those passive surveillance surveillance systems that include, for example, how we found the Missouri case. We have reporting, that's how we identified the cases in Texas. And we might look at bird migration and say, Pacific flyway, alert, alert, alert. We do this active surveillance, like testing the cows before we ship them. We reassess our risk through a formal process with the CDC, and that might trigger additional activities. But I think there are some other places where we could enhance what we're doing to help prevent the opportunity for this virus to lead into a pandemic. So if we focus on the surveillance systems, you know, our major outbreak right now in California happened despite mandatory testing. There are rumors, you know, word on the street is maybe there was some cow movement. Possibly there was some testing at some point. But clearly, this is occurring despite this ruling. We know that our passive surveillance systems like FluNet are probably not capturing the communities in which our workers live. We know that our wastewater surveillance programs are not designed to catch people on septic in rural communities or any of the dairy wastes. You only find it if the processing plant is connected to a wastewater surveillance system. Are we looking at dogs and cats? Yeah, there were cases in Colorado, including indoor-only cats. Now, could the cat have gotten out and they just forgot? Maybe, but these are domestic house cats that were included. And we have these inconsistencies in data sharing. You know, our animal systems and our human systems, and now these new wastewater systems are not designed to be connected to each other. When we think about interventions, you know, I think about a lot of things from an occupational health perspective. So this is our traditional hierarchy of controls. This is what NIOSH says, do the things that are more effective more of the time, and your least effective things like please wear N95 masks and Tyvek in 104-degree heat, right, are kind of your last ditch scenario. So Dr. Dalton and I were thinking of this first in the context of hospital systems, but it applies pretty easily into this context where maybe we need to redesign dairy parlors. Maybe we need to improve the biosecurity and think about ways of doing that, but still allowing for good respiratory health for the cows. What about changing the way we have flow of work, segregating high-risk activities, using shorter periods of time that people are in the PPE in order to make sure that we're mitigating these other risks like heat stress? Why don't we redesign PPE? How many people work in healthcare and would love us to redesign PPE, right? I think this cuts across the board. How do we engage our workers? Yes, there are vaccines. We've had vaccines for quite a bit of time, since about 2005, although those don't always have the best cross protection with current strains. There are specific 2344B vaccines that have been developed through a number of vet schools and others that I think are in field trials at this point. And we've got our, candidate vaccine virus was prepared pretty early in this process, and we have an initial stock of human vaccine. But there's this wonderful thing called DIVA, differentiating infected from vaccinated animals. There are the most complex trade agreements between many different countries. So if the US is exporting and a country doesn't have a test that can differentiate you're vaccinated from you're infected, then if they say you're positive, we can't accept this product, that is going to influence the decision making by your 25,000 farmers of dairy cows. It's going to impact your decision making of all the poultry farmers. And if it gets into swine, ooh. All right, so participatory approaches are really, really critical from a communication standpoint. So one of the things that I think would be very helpful for us is to think about animal health more broadly, not just focusing, as the USDA does, largely on food-producing animals, but including your companion animals. Environmental health folks, how many of us do infectious disease work? Right? It used to be the core of environmental health, and it's now, it's a niche. We got a little group of us who keep plugging away at it. But that means that in a state level government position, you're environment, people may not understand infectious diseases in the same way. Although that is changing with wastewater surveillance and its potential utility in so many things beyond COVID and H5N1. But you also have these less traditional groups, that aren't part of that normal flagpole, including like animal shelter organizations. You also have veterinary care deserts. So there are lots of places where you don't see veterinarians. And a lot of these are rural, and they're not just for livestock. This is also for companion animals. So if you're relying on notification from a USDA accredited veterinarian, if you don't even have one of those within 100 miles, are you doing surveillance in that area? Probably not. Some emerging challenges, and this is just a fun picture of a duck in downtown Denver at a food kiosk where there was some feeding of the duck occurring. So human-animal interface in Weld County. Well, no, Denver was just south of Weld County where the outbreak was. So just saying, this even applies in urban environments. But we also have the challenge of raw milk products. Happy to chat about that. The cats and other pet species, this wild bird interface. As I said, the disease ecology, especially with these peridomestic rodents. Integrating our surveillance systems. And I, of course, am very interested in what this means in terms of the well-being and mental health of our veterinarians, our frontline workers, our producers, right? This has got to be a challenging moment. It's very stressful. And so how do we help support all of these functions? I like to say that One Health is where everything overlaps. Where it doesn't is important, but it also means that there's a lack of shared responsibility to address the challenges. And so trying to move more of the VEN into that integrated space is one way that we can help to support shared responsibility to address the challenges. And thank you so much.